Ryan Stanton here with ACEP Frontline, and today at LAC, and great panel discussion on boarding, something that a few of us have heard about on occasion. And so, we're starting today from the panel itself with Helene Anderson and then with Jonathan Jagoda. And then joining us as well is Amy Downmall, who will be with us as well. We're going to start with Jonathan because Jonathan has a call just with everything policy in DC, the schedules to the minute. Thankfully, he pushed it back for us just a little bit. So give us a little bit of the landscape right now, the regulatory aspect of what you're seeing with regarding to the boarding crisis.
Members of Congress are certainly aware of the boarding crisis that's happening in the United States, but it's really important that ACEP and the emergency physicians in America come to Washington, D.C. and remind them of what's going on every single day and how data and other systems out there can play a pivotal role in making sure that EDs are able to receive patients and treat them in a timely fashion when every second counts.
And how do you see any recent changes? Because as boarding has been an issue, of course, it was exacerbated by COVID, and now we're seeing other things come into play. From your regulatory aspect of it, what kind of landscape changes are you seeing that may play into our efforts moving forward?
We're seeing a lot of changes, obviously a lot of restructuring and reforming of government, especially at within the administration. But what's critical is that we keep our eye on the ball and that we continue to talk to the administration and emphasize the importance of preparedness, especially whether it's a man-made or natural disaster or another pandemic. These things will happen again, and it's so critical that the administration continue to invest in, as I said before, systems that can help support EDs and help relieve the boarding crisis that's leading to physician and workforce burnout and just stressing the system.
All right, so that was the key of the discussion today, was really talking about some of the technology and bringing in technology into kind of what we're dealing with from the boarding aspect. Actually, a great question. I'll end up with Amy here at the end, having to do with some of the transport aspects of it that my system has. But Helene, kind of give us a little background on, kind of set the stage of the discussion you all had in bringing in technology to boarding.
Well, as I mentioned, you can't change anything unless you can measure it. Anecdotal experience is critical, but so is data. And the two together are very powerful, which is why I'm so excited that they're going to be doing Hill visits tomorrow, because I hope they can integrate those. And I know they'll be able to. And when they do that, I think it'll make a huge difference. But data is important because it does a couple of things. It helps quantify an issue to determine if it's something that affects everybody. It helps myth bust, if you will, things that are just live in people's memories or history that was maybe a terrible experience, but still very present for them. And it also helps delineate what could be managed with policy or advocacy, and then what might be clinical in operations. So for example, patients who no longer require or no longer meet medical necessity for admission. We refer to those as avoidable days in Oregon. When we did an analysis on the data, we noticed that some of the patients who were stuck, for lack of a better word, well, because the team didn't agree. But if you lump those into all patients who were stuck, we can't influence the team maybe not agreeing on the course of care, but we can influence with policy the availability of beds or the funding or the reimbursement mechanisms. So data helps us discern the critical elements and look where there's common opportunity to impact.
And, Jonathan, before you head out, we're going to take advantage of you before you go and fight the good fight on our behalf here in the next few minutes. We're hearing about data, and we're hearing about Oregon with some of these avoidable days and things like that. We have the stories. From a regulatory and DC standpoint, why is the data important in terms of supporting what we feel and see in emergency medicine?
Because what we're seeing from the top down in government, from the administration and Congress, is they want to do a lot more with less. And therefore, we're going to have to look at things like data, automation, things that help take the burden off of the providers in an ED, things that'll help hopefully reduce costs while certainly working to improve patient access and improve patient care.
I appreciate your time. thank you for spending with us. Thanks for the wonderful segment
Thank you.
for you.
Appreciate it.
And as you make your way, as you make it to your meeting, and thank you for being willing to push that back for us.
Thanks.
So that's what it means to us here at ACEP Frontline. As Jonathan is now late for a meeting for us for you right now. So appreciate that. Amy, give us a little background and your role in this and what you see in terms of the boarding and the challenges that we're facing.
Well, kind of hearkening back to what you were speaking to and what we touched on during the conversation, or Helene and Jonathan did, with a question around EMS and transportation. I am a nurse by background, and I have worked in both inpatient ED, transfer center environments, so the movement of patients into and between hospitals and emergency departments I'm very familiar with. I think that for day-to-day operations, data is also very important, and in such that when we're looking at the boarding, the census, the crowding in our emergency departments, and the decisions that if you have options in your community about the hospitals that you can take your patients to, the decisions that EMS can make out in the community setting when delivering patients to an emergency department, depending on what the need is and what the service provided, at specific hospitals, can we decide in the field that, hey, this hospital, they're way crowded, they're way over census, their boarding numbers are up. Can this patient that maybe could be treated at any hospital, could we take him to the one that isn't quite as impacted on this day at this hour? And so how do we take this data and this information that we have readily available in day-to-day operations and make it useful and for patients to have more ready access to care and to alleviate, some of that pressure that's happening in the emergency department?
And we know that not all boarding is created equal. Sometimes it's just sheer overcrowding. When I worked for the university system, it was just the fact that it was an all-comers. The system where I am now, it waxes and wanes based on staffing. Holiday weekends are always very difficult because somehow everybody gets sick at that time and can't come to work. And so
Mother's Day.
we have beds available. For us, it's always Labor Day and Memorial Day because it's Monday, so Saturday doesn't count.
Yeah.
And so there's a huge absence. And of course, there's just a shortage in general of nursing and techs and folks to really make the wheels turn. How can data, and I'll let you both respond to it, is how does data impact that in terms of we can get data and see the global 30,000 foot view, but then digging into some of that granularity that demonstrates what each system may have, because fixing a problem in one may not even touch the same similar problem somewhere else.
So you've kind of seen one hospital,
Exactly,
Right.
yes.
I think there's an interdependence in communities about this. We were working with a colleague in Delaware who raises her hand and says, I need patients. Well, how do you let other people know that? And, they're smaller, a little in northern Delaware, a little closer to Philly market. And this system, her hope is that it allows people to say, well, go here. I can offload that. When it comes to the data to drive some of these solutions, even the virtual capacity that people have is kind of unknown. So part of what we've seen make a difference, whether it helps one, doesn't help the other, is to level load that situational awareness so that everybody has the same information at their fingertips to make a decision that doesn't disadvantage the place that always says yes, or the academic medical center, to the place that's raising their hand saying, I can take these patients. I can do these general surgeries, I can do these. So how do we raise that information so people understand where they can optimize so that they don't have to feel overwhelmed, overburdened? It's kind of very difficult to be in an ED or in a hospital and you're drowning and somebody who's 3 miles away is not. And you naturally start questioning how can this be different? So the data that was in people's minds that now we can expose to them without fear of impacting market share or or things that kind of impede growth in any particular location or hospital system can really be used to do what we all want, which is kind of meet the patient's needs where they can get the care without delay, because we know that delaying them has this other course of events that are generally never good.
Well, we did get a question right at the end because it was deferred to you when from there and looking, because my facility is one that I mentioned the staffing, the call-ins on occasion, like this year during flu season, RSV. Actually, it was all of them. We had everything. We had the overcapacity, the overcrowding, but in the end, it really had to do a lot of times with patients who we couldn't get necessarily out. In emergency medicine, that becomes even more difficult because you have a patient that comes in and then we can't get them home. They don't have a way to get home. Nursing home patients, long-term, just mobility challenge, whatever it may be. And so the system started its own EMS service. And all of our large systems in Kentucky have their own EMS service, except one. Theirs is coming together. And so talk about some of those solutions. You mentioned some of that aspect of alleviating some of these things without just building another 3 floors in the hospital.
Getting people out it's so multifactorial. I was the story the one gal was sharing about the patient that they're assessing, and she's like, I think this patient has dementia, and I don't think they can go back on to their home by themselves. And the layers of getting that patient discharged all of a sudden becomes more than just a transportation issue, right? and the services that need to be investigated. But when thinking about how do we move the patient to that next discharge or level of care outside of the emergency department, right, wherever that might be. And I think that's still, it's so multifactorial. There's not a simple answer to that question. And I think some of the work that we do, not only for with the avoidable day data that we collect, now granted that's inpatient data, but again, we're seeing those patients initially in the emergency department, right? And they're coming in with these issues. So how do we identify that early on in order to get them out? Is it a quick fix to that same day, discharge? No. But also the problem solving around non-emergent medical transportation and getting people home. And how do you utilize and think outside the box of what other options that are already pre-existing in your community without having to home grow your own solution or your own transport within the hospital. There's so many
but certainly we've seen centralized transportation hubs that are within MOCs or other large systems that have said, if Mr. Jones is going home tomorrow, or Wednesday, and it's Monday, that Monday I'm making that reservation for him, because with some of the ride shares or brokerages, that same day they'll tell you it's going to be in 2 days. Right. So how can we work in partnership with the inpatient teams to kind of plan for that, so that we're not working on it the day it's needed? So we've had some, and we've heard from others in the other states that we're in some really good success stories around this without having to invest in their own transportation company. But we're still up against, it's kind of like a bad system beats a good person every time. The ride system and the reimbursement, which doesn't even exist for, the behavioral health needs at secure transport. How do you get around that? It requires us to come together in a way that maybe we haven't done as well, to advocate for things that we're all feeling pressure about. It could be a state solution, could be a system solution, but all we're doing is passing on the buck, and then you kind of run up against other things about I love the inducement of services risk, because you're inducing somebody because you can give them a ride home. It's never made sense to me, but they expect you to have room for the next patient. So how do we kind of balance those things? And I really think that's where the advocacy work and the associations likely have a good first pass at that before they elevate it to the national level.
I think the challenge is not only from a single facility standpoint, system standpoint, state standpoint, and federal. Every single piece of that has a wall of separation that makes it difficult. So as we wrap up today, kind of look in the looking glasses. This is one of our primary advocacy efforts, is the boarding crisis, because it's impacting most emergency departments across the country. How, kind of what you see in terms of opportunities moving forward, and then a little bit more, details on what you're doing with the data and that information and implementing that and kind of using that towards the boarding crisis.
Well, I think, as I mentioned earlier, I think data with a narrative is probably the most clean way to illustrate the challenge. And, when Jonathan and I were talking earlier, when we met with some of the Senate and House staff on prior visits, they know what boarding is. They have general constructs of what they think it means, but it's really different when that story gets humanized. And when we started talking about some of our case studies, which I think, we pulled together with data and a real example. Like you don't have to make this stuff up. Like sadly, you see it every day. So taking those two together to the right audience, I think is really powerful. And then we strive to make sure that our data constructs are around something central. So we were just talking, somebody said, well, it was the Connecticut team, and they were talking about how they landed on the boarding time definition is different. So that already, if you have to adjust go into it with the right data set, right? And even if it's not right and you're reevaluating it to make it better, but having that agility to kind of, because what we think we might measure might not be where we know where we start won't be where we end, right? So I think having that group of subject matter experts that can tell us what's helpful, what we're seeing, and then kind of using all of the variables like Amy was mentioning, it's really complicated, the pre-hospital score, the hospital score, the staffing, the surgical volume to bed. We want the lights on. So how do we weave those things together to kind of say, this is what we thought, and here's the proof.
Amy?
And bringing a light and continue to bring a light to the challenges of the post-acute and the behavioral health, because patients are boarding the emergency department because we can't get them up to the floor because they're, it's that continuum of care that we have to ensure that people understand that it doesn't just stop in the ED, it doesn't just stop in the hospital proper. It's what's available out in the community as well that we can get our patients to, so we can see that next acute patient in our hospitals.
Can I add primary care to that?
Oh, absolutely.
Right?
And primary
Yes.
care, yeah.
How can folks get in touch and get more information about the data and if they have questions for you? Because you had a line going out the door
I did?
when we wrapped up today.
What was that?
Oh, just for everybody asking questions, following everybody. had their thoughts.
Yeah, let me know. So Apprise Health Insights, if you look at the healthcarecapacitysystem.com, and then we have very long emails, but mine is Helene, Helene, _Anderson, at apprisehealthinsights.com.
And amy.downmall@apprisehealthinsights.com.
So Helene Anderson,
Ryan.
Amy Downmall,
Yeah.
appreciate your time. As for me, it's pretty easy on this one, rstant@acep.org, rstant@acep.org. Thank you all for your time.
Thank you.
We thank Jonathan as well. But as mentioned, he had to run. So until next time, I'm Dr. Ryan Stanton. This has been some ACEP Frontline.